if the T is down or if the office is not in an accessible location, I literally cannot receive the services that I need and the medical care that I need.
I can't remember the last time my doctor saw me fully naked because he doesn't have accessible exam tables.
People with physical disabilities often have problems accessing mental health or behavioral health services.
Being able to view the world from someone who's sitting down in a chair, that's the step that goes the farthest in terms of making things accessible.
I wanted to tell you about my journey of deep learning that began over 30 years ago. It began on a hot summer night at the Urban Medical Group Clinic in the Jamaica Plains section of Boston, when 6 charter members of Boston Center for Independent Living wheeled in carrying 6 packs of beer in preparation for a long evening of dialogue. They were really in the vanguard of a human rights and civil rights revolution that was every bit as inspiring as the civil rights revolution led by Martin Luther King a few years earlier. They had spinal cord injuries with paralysis in all limbs. In some cases, there were people with neuromuscular disease for a number of years. In other cases, it were people that since birth had significant physical disabilities like cerebral palsy. They were in search of a medical partner to help them deal with the most daunting obstacles to their goals of independence, autonomy, and a meaningful life. The fact is that medical care was designed more for the priorities and needs of those providing the care than those receiving the care. And it worked for the vast majority of people, but it didn't work for others. What were some of the things that they told me? They said, well, first of all, they really could not make a primary care appointment in the early or mid-morning. Just the effort to go from bed to chair, toileting, eating, dressing, and ready to go in the day took, for some, 2 to 2.5 hours with a personal care assistant. So how could you make a 10 or 11 o'clock appointment? Secondly, the only way that most people could make appointments was from the publicly funded ride, but the rides were notoriously unreliable. In addition, when people came to the offices, there were physical barriers. An exam table was 5 feet high and did not move down. There were also very significant attitudinal barriers, values barriers as well.
Our patients would see this all the time. You know, they would go to a specialist, perhaps accompanied by a personal care attendant because they needed physical assistance with things. But the specialist would end up interviewing the PCA as if the patient wasn't even there.
All of these barriers conspired to limit opportunities to live fully and freely. And the key point was the most daunting obstacle really was the medical care system.
Nearly 40 million Americans, 12.8% of the non-institutional population, report living with a disability, and almost everyone is impacted by a disability at some point in their lives. Particularly as our nation ages, more people are living with chronic illness and disability. When we talk about disability, we're talking about functional limitations that result from physical, intellectual, or developmental, sensory or behavioral changes. This is a diverse group of people, all ages, genders, ethnicities, races, religions, political affiliations. More than a quarter of people living with disabilities, 12.3 million, need assistance with either self-care or daily activities. Among these individuals are a significant subgroup of people with involved disabilities. We define this group as individuals with limited ability to perform most activities of daily living, such as bathing, dressing, toileting, and eating, a very low threshold for predictable medical complications that cause most hospitalizations and are an immediate threat to health, independence, and life itself. Compared with the population overall, adults living with disabilities are more likely to be unemployed and low income. Many rely on public health programs, Medicare and Medicaid, for their health care. Even with health care coverage, people with disabilities have faced challenges to getting care that meets their unique needs.
medicine operates on the principle of curing or fixing. And as a person with a disability, I was clearly coming into my own life and could see that I could get by very well. I was walking with crutches. I learned how to drive. I was getting ready to go to college. There really wasn't need to fix me. I was already a person participating in real world activities, and I didn't need to be fixed any further.
The 1960s expanded health coverage for people with disabilities. At the same time, the liberation movements of this era spurred a wave of civil rights activism among people with disabilities, the independent living movement, which culminated in the passage of the Americans with Disabilities Act in 1990.
Pre-1990, it was legal to discriminate. ADA brought in public accommodation, which is access to public buildings, access to state and local government services, access to transportation, employment discrimination, all of those things. The ADA brought us our freedom, our equality. That's why, I tell people all the time, my Independence Day is not July 4th. It's July 26th.
I now lift my pen to sign this Americans with Disability Act and say, let the shameful wall of exclusion finally come tumbling down.
The independent living movement redefined the problem of disability. Rather than seeing the individual as the problem, the focus of the problem was the environment, which was not designed to accommodate people with functional limitations. Despite these changes in law and attitude, barriers to quality health care for people living with disabilities persist. We can see this in the disparate outcomes for people living with disabilities.
The traditional medical model sees people with disabilities in terms of their medical and functional problems, which we, doctors, nurses, nurse practitioners, as experts can improve. But that is not what the people who came to me were looking for. They were looking for a partnership. What did that partnership look like? It started with a recognition of individual expertise over a lifetime that was learned through oftentimes painful lived experience. They were looking for what we call today the dignity of risk, the right to choose and the right to fail, which is basic to one's humanity. And they were looking for self-determination. Self-determination was absolutely essential to the goals of autonomy and independence. It's a human rights value. And without self-determination in medical care, there could be no self-determination elsewhere. In other words, it is incumbent on me as a physician, as I came to learn, to recognize whenever possible that people with disabilities are the experts about their lives and their needs. To do this, I had to unlearn years of training and years of socialization. I cannot be the only expert in this room.
It would be most helpful if medical practitioners treat their patients more like partners, find out what they want and what their needs are, being open, earning the trust and respect of the person will help you to partner with that person.
How do we honor these principles in caring for individuals with involved disabilities? We honor these principles through a fundamental redesign of how care is delivered.
To provide person-centered care to people with involved disabilities, we have to make significant changes in the culture of medical practice. Some of these changes require shifting our mindset and values and can be adopted regardless of the setting in which you work. Others require a broader redesign of the primary care system. We will be talking more about both culture change and practice redesign in subsequent modules. In Module A, we explored how people with disabilities fought for their rights and how medical care needs to change to support the values of independent living that were at the heart of that struggle. We learned that the traditional medical model does not work well for people with involved disabilities. To improve care for people with involved disabilities, we need a person-centered model of care that values consumer expertise, dignity of risk, and self-determination as the basis for a true partnership.